made for TV series. Please welcome the doctors. So, wow, it's really great to be here. Let me just change my glasses here. Just got this. Have you heard of these new Meta glasses? They're like $700, but I got these for $70, and they're like exactly the same. All right, so where do we start? Let's start with how we got here today, because this is Dr. Schranz and I first NCA Todd conference, which is kind of surprising because it's like there's almost 300 people here, but you all are the best kept secret in North Carolina. We really need to get the word out because Dr. Schranz is his research, as you heard, is on the intersection of addiction and infectious disease, and it's kind of a niche thing, but it puts him in a unique position to inform you all about infectious disease and how it relates to specifically opioid treatment, opioid use disorder. Because as you know, a lot of our clientele are IV drug users, and that's the #1 risk factor for infectious disease, especially hepatitis C, HIV, hepatitis B, and others. And that's what we're going to talk about today is infectious disease and best practices, because after all, this is NCA Todd, best practices in opioid treatment disorder. Thank you so much to Virginia, Elaine, to Arthur, and what's the president's name again? Kenny, for this opportunity to speak. I am a nurse practitioner, and I work with Crossroads Treatment Center right here in Greensboro. So give a shout out to my team right here. I feel like everything I've done in my career has led to this moment, working in addictions medicine. I have been associated with the program director at Crossroads for about 25 years. We worked together when her son was knee-high to a grasshopper, and now he's on the Greensboro PD. And I was her supervisor, and now she's my program director. So I guess I did okay as a supervisor.
Fantastic.
So let's get right into it. This first slide is something that we always say: we have no potential or actual conflict of interest related to this program for NCA Todd. We're not sponsored, although you're going to hear about a couple of different medications and pharmacological things. We're not sponsored by any drug company. Some of the data that was used in this presentation is that which Dr. Schranz has done is in his academic role at UNC. And he, of course, was sponsored by different grants from the National Institutes of Health, Up to Date, which is a Walters Kluwer company, and Sage Publications. This session is going to be talking about the burden of HIV and hepatitis C, and a little bit about infective endocarditis in rural communities in North Carolina. You all saw the objectives, and so I don't need to read those to you, but we're going to talk about things like syringe service programs, Project ECHO, harm reduction expansion, co-located services, and improving prevention and treatment of infectious disease as it relates to opioid use disorder and the greater addiction clientele. Right there is your learning outcomes. So first, I think we should talk about hepatitis C. I should also say that Dr. Schranz and I have not presented before together, and I think that after today, he probably won't ever want to present with me again, because we are kind of different. We were talking about this presentation, and I was saying, well, when I present, I like people to interrupt and ask questions, and that's because I'm kind of ADHD, and it helps me keep my focus off of myself and on the audience, because it's not all about me. Dr. Schranz, on the other hand, is a traditional presenter where he likes to present and then takes question afterwards. So we're going to compromise here. What we're going to do is you have in front of you some note cards, and if you have a question or something comes up, be sure to write that question down, because by the end of the presentation, because we've got like an hour, by the end of the presentation, I guarantee you're going to forget the question that you were going to ask. So write it down so you can have it at the end. But if there's a burden question, like something is really confusing or muddy, feel free to raise your hand, and I'm going to run a mic out to you so that you can get that information to you. When we first did this presentation, it was really heavy in pathophysiology, and Dr. Schranz said, you know what? Looking at our audience, we've got plenty of nurses who will understand that, but the majority of our folks at the conference, this pathophysiology is going to put them to sleep. It's not exactly what he said, but I took it for what he meant, and that was the beginning of this is talking about hepatitis C overview, and he boiled down about 50 slides of pathophysiology because I teach nursing. He boiled down about 50 slides of pathophysiology into one slide, which was amazing. Yes. Absolutely amazing, because that's the hardest part when it comes to writing papers for me or doing presentation, is paring it down. I can make a slide presentation of 200 slides, but to make it succinct, boil it down to what it is, that's really hard. And I think it was Walt Whitman who said in a letter that he wrote, I would have written a shorter letter, but I didn't have the time. And it's true. You can write, but if you want to make it succinct, like poetry, it takes a lot of time. So for context of this, we're talking about viral hepatitis. And we've got hepatitis A, hepatitis B, hepatitis C. There's even hepatitis D and E. I'm old enough to remember when hepatitis C was first discovered. And it's kind of funny, I don't know if Dr. Schranz remembers, Asher. I don't know if Asher remembers this or not, but when hepatitis C, and some of you are oldsters like me will remember this. Do you remember what they called hepatitis C when it first came out? I think I heard it out there. They called it non-A, non-B hepatitis. So they were like, they didn't have a name for it. They just said, it's not hepatitis A, it's not hepatitis C, it's something else. But we know it's hepatitis. So now it's hepatitis C, and for goodness sake, we have D and E as well. They have different types of transmission, and mostly what you need to know is that hepatitis A is foodborne, and the route of transmission is kind of gross. It's the fecal-oral route. Ew. So the nurse in me says, don't forget to wash your hands, because UNC School of Nursing did a little study on cell phones where they took everybody's cell phone. Don't say it, right? Because what do you do when you're in the bathroom? You're on your cell phone. Oh. And they found so much E. coli in cell phones when they grew it. So fecal oral route is the transmission of hepatitis A. There's sporadic outbreaks in North Carolina. There is a vaccine available, so that's good news. Although it's not often given because unless you're in a real high risk factor for hepatitis A, it's not indicated. Hepatitis B transmission, this is a bloodborne pathogen. So it's blood exposure or sex or perinatal transmission. There is a vaccine, but the older vaccine is less effective even in healthy individuals. And as you know, as healthcare providers, hepatitis B is indicated for everybody who works in healthcare. Why do you suppose that is? Here's the teacher in me asking teaching Socratically, why do you suppose that everybody in healthcare gets the vaccine for hepatitis B? Anybody? Exposure risk rate. Well, listen, are you worried about getting hepatitis C? Are you worried about getting hepatitis A? Or are you worried about getting hepatitis B? Or are you worried about getting HIV? You should really be worried about getting hepatitis B more than anything, because it's about 300 times easier to catch hepatitis B than HIV. So if there was a drop of blood on this lectern right here, and it came from an HIV infected patient, I could lick it with impunity. Why? Because HIV, why would you want to, right? Because HIV cannot survive outside the host. On the other hand, if this had hepatitis B, this drop of blood, it could dry up and sit there for 30 days and still be effective. So that's how easy it is to get hepatitis B, and that's why you should be worried about it. And make sure that you are vaccinated, especially if you work in healthcare. And even if you are vaccinated, you might even want to get your titer checked, because after all, the older vaccine wears out. Hepatitis C is the one that we deal with, I think, most frequently in our population of IV drug users. The transmission is a bloodborne pathogen, injection use mainly, or transfusion prior to 1990s. That's why all the baby boomers in this room, if you haven't already been tested for hepatitis C, which I'm preaching to the choir, of course you have, you should, because prior to the 1990s, they didn't know that hepatitis C even existed. So you could have hepatitis C and not even know it. So anybody who is age, I think the indication now is age 65 or maybe even less. But anybody who is that baby boomer age needs to be tested, if they're not already, by their primary care provider for hepatitis C. Why is that? Well, because when you first get hepatitis C, it feels just like the flu. It's just a flu-like infection, and you get over it. That's the acute phase. The chronic phase can last 30, 40, 50 years, and you can have no symptoms, almost like hypertension, which they call the silent killer. Hepatitis D and E are far more uncommon in the United States. So we're going to be talking mostly about hepatitis C, because that's the one that we deal with the most. As we said, it's injection drug use. This was one of the 50 slides that I had that Asher boiled down. This is a really neat graphic right here, the progression of hepatitis C. For every 100 people infected with the hepatitis C virus, 75 to 85%, or 70, well, percent is because if we're saying 100, 75 to 85 of them will develop the chronic infection. 60 to 70 will develop chronic liver disease like cirrhosis or liver cancer. 5 to 20 will develop cirrhosis, and 1 to 5 will die of cirrhosis or liver cancer. So what happens to the rest of them? Well, some people, you've probably heard, will spontaneously get rid of, their body immune system gets rid of hepatitis C. You probably heard 1 or 2 of your patients say, I tested positive for the antibody, but they tell me that my body fought it off. It's pretty rare, it's like 3 or 4%. And also, Dr. Schranz, being on the forefront of research, is going to correct me if I'm wrong on any of my statistics. About 3 or 4% of people actually are able to fight it off. Their immune system actually develops antibodies that they fight off hepatitis C. The rest of them who get hepatitis C are going to end up with chronic hepatitis C, and at the end of life, are going to end up with things like liver failure, cirrhosis, liver cancer. Their best bet is to spend their last few days in the ICU, which nobody wants to see. So we want to avoid that, if at all possible, because if left untreated, these patients will end up with cirrhosis and liver cancer. Hepatitis C can present, as I said, totally asymptomatic. or a non-specific illness with elevated liver enzymes on labs. About 25% of patients will clear spontaneously. Well, that's a lot higher than I said, 3 or 4%. The rest progress to chronic hepatitis C. Here's the history. We slowly progress to fibrosis. This is a really great slide. So fibrosis is also known as scarring of the liver, because the liver is really a robust organ. It heals itself really well. You can damage your liver and it'll come back with a vengeance. It's not like other organs in your body, like your kidneys, where if you destroy your nephrons, the functional unit of your kidney, they don't grow back. Or your brain, you destroy brain cells, go out for a bender one night and kill off a couple million brain cells. Those are not coming back. Liver, on the other hand, very robust, can regenerate itself, but it gets scar tissue when it heals. So eventually, over decades, this scar tissue develops into cirrhosis, which is irreversible scarring of the liver. Cirrhosis is associated with impairments in liver function and increased pressure on the belly, and can cause esophageal varices, which are like varicose veins in your throat. Ascites, which is fluid accumulation, and kidney failure. Within this milieu, love that word, it's a French word, milieu. It literally means in the middle of. Within this milieu, the liver can stop working altogether and liver cancer can develop. It's highly transmittable among people with, what's that stand for again?
People who inject drugs.
People who inject drugs. I was thinking people with infectious disease. That those acronyms we love to use. People with infectious disease are highly transmittable. Yeah, of course. No, people who inject drugs, extremely common. Greater than 40% of people who've injected drugs have been exposed. So when you do an intake at your OTP and you have someone who says, yes, I tested positive for hepatitis C, you can almost know the answer to the next question. What kind of drug did you use? And how, and what was the route? Injection, right? Or vice versa. You have someone who you know is uses injectable drugs. You can almost guarantee that they came down with some type of infectious disease. They go hand in hand. It is 10 to 30 times more transmittable by needle stick than HIV. So the chance of getting HIV from an accidental needle stick are very, very small compared to hepatitis C. Like I said, it's 300 times easier to catch hepatitis B rather than HIV, and hepatitis C is similar in that it is much more transmissible. The particles survive for long periods of time on surfaces. In medicine, we call those fomites. So in syringes and cottons, it's transmittable primarily by blood exposure, not sex, like other bloodborne pathogens. And there's no vaccine available or in the near future for hepatitis C. Epidemiology, this is the prevalence and incidence. It's most common in people aged 20 to 49. Injection use is far and away the most common risk factor. More than half of acute hepatitis C virus cases in 2023 were among people aged 30 to 44 years of age. And chronic hepatitis C is most common among persons 30 to 39 and 65 years and older. That's the baby boomers we're talking about. The diagnosis is made by a couple of different tests. An antibody test that identifies if you've ever been exposed to hepatitis C. If it's positive, that means that you've been exposed to it at some time or another, but it doesn't determine whether you are actively infected or have the disease or not. If the antibody test is negative, it means that you have either never been exposed to Hep C, or it's early enough in the infection that you have acute hepatitis C. It's something we call seroconvert. You haven't seroconverted yet. A hepatitis C RNA, also known as the viral load or PCR test, determines if there's a current infection. If it's positive, the patient currently has hepatitis C either in the acute phase or chronic. This next slide shows a really good graphic of what all of that means. And you'll get a copy of this presentation, by the way. So if you're negative for the antibody and negative for your viral load, there's no current or prior hepatitis C virus. If you have the antibody, but you don't have the RNA, that means that you were exposed at some time, and the hepatitis C either spontaneously cleared itself or you were successfully treated. And then, of course, if you have a viral load, it doesn't matter whether you have the antibodies or not, you are currently have the hepatitis C infection. So this is how we differentiate whether you have the antibodies, the disease, or the current infection. So, should you send somebody for an antibody or RNA? This is a good question, especially for you medical providers and nurses. Do you send somebody for an antibody or test them for the viral load? You send somebody for an antibody test if the patient has never been tested for hepatitis C before and they have no recent high-risk exposure, primarily injected drug use. You should send them for the viral load if the patient has had a recent exposure, such as injection drug use, or known sex partner with hepatitis C virus. The patient has had symptoms or signs of acute hepatitis C, or if they previously had antibody tests but need to be screened again. So in other words, the antibody test is your screening. The RNA is your definitive diagnosis of whether they have either been exposed or currently have the disease. So for many labs, we'll do a reflex, a positive antibody to an RNA test. In other words, they'll run it automatically. Hepatitis C treatment, this is the exciting part, because I remember when the first drug came out to treat hepatitis C, it was pretty exciting. Harvoni came out, and it was really a watershed moment. It was quite amazing because it's not just a treatment, it's the cure. Harvoni was the cure for certain genotypes of hepatitis C. You took this one pill every day for 90 days, and you were cured of hepatitis C. Amazing. Now this kind of goes against a lot of things that you hear about drug companies, right? You hear about drug companies, they don't want to cure diseases, they want you to just keep taking medication for the rest of your life. Well, this is pretty exciting because hepatitis C is curable. Doesn't mean you can't get it again if you've been cured, but it does mean that you're not going to end up with the chronic hepatitis C, cirrhosis, liver failure, liver cancer, spending the last few weeks or months of your life in the ICU. Now, when this drug came out, going a little off script here, if you don't mind. When this drug came out, it was not advertised, but it had an infamous, kind of dubious honor of being called, it was called the $1,000 pill. Because one 90-day treatment cost $90,000. Yes. But how do you put a price on your life? I mean, if you knew that you had hepatitis C and you needed to get this drug, Harvoni, would you not come up with $90,000? I mean, you would, yeah. I mean, I would put another mortgage on my house for that. Because how do you put a price on life? Well, apparently, drug companies can put a price on it, and it's $90,000. But funny thing is, in my previous life, I worked for the North Carolina Department of Correction. And although North Carolina does a lot of things backwards in the prison system, one of the things they did right was when Harboni first came out, the legislature decided in North Carolina that anybody who became incarcerated in the prison system, who had the right genotype, of course, would get Harboni. Now here's the Socratic method of teaching again. Why do you suppose the legislature decided that anybody, because you know it's free, the taxpayers pay, foot the bill for all the medications that people who are incarcerated get. Why do you suppose the legislature in North Carolina decided anybody who has hepatitis C who's incarcerated is going to get Harboni? Any answer? Raise your hand and I'll yes. That is the reason why. Give this lady a prize. There's two reasons. What she said should be the number one reason, but that was, it is the number one reason. The number one reason is actually the number two reason. The number one reason should be because it's a public health initiative. Because while they're incarcerated, they may be discharged someday, right, from prison. So while we have them as a captive audience per se, let's go ahead and cure them of the disease. So when they get out, they're not going to spread it to the community. Or, on the other hand, they're not going to spread it amongst the inmates. So let's go ahead and cure them. That's why they should have done it. But the real reason always boils down to money, right? In the long run, remember I said that your best bet is to spend the last few weeks or months of your life in the ICU? Conservatively, you go to UNC, and it's going to cost you about $10,000 a day, conservatively, to stay in the ICU. So they looked at this and they said, well, we can spend the money now or we can spend the money later. And it's going to cost a lot more money down the road if this person is still incarcerated, because we're going to have to put him in the ICU. And because they got a discount for buying a lot of it, the drug company sold Harboni, the drug, to the North Carolina, the state of North Carolina, for just $50,000 per person. Now we've got a new one called, we've got two new, we're really one, but I'll tell you why later, it's just one. We've got two new drugs out there, Mavorite and Epclusa, which are a lot cheaper than Harboni. They're not really affordable, and of course, if you have private insurance, your private insurance is going to say, no, that's all on you. It's not. It's going to be totally out of pocket for you. But we've got new treatments available. What they call direct-acting antivirals, or DAAs. Today, they're easy, highly effective. There's lots of options. Like I said, you take one pill every day for 8 to 12 weeks. It's very well tolerated with few side effects, few drug interactions, and most regimens have no interaction with the opioid use disorder population. And why I say most is because we're going to talk about why one is preferred over the other in a moment. The idea is that you treat all patients with a positive RNA test. However, the general principle is that regardless of their substance abuse status, and regardless if they have acute or chronic infection, you're going to treat them. Also regardless of whether they're going to continue to use. Because after all, you can cure them of hepatitis C and they can get it again.
Just interject for one moment.
Thank you.
Say, my experience actually, yes, early on these drugs, so there's long been treatment for hepatitis C. Some of you guys who worked for a long time or worked for patients who've been around a long time, they may talk about what we call, sometimes patients mention it, the interferon era, or injecting medications to treat their hepatitis C. These were like very difficult drugs to use. They had a lot of bad side effects, and were not often successful. And so when Harboni or Lipisphere, Sofosbuvir, kind of the first of these DAA drugs came out, really kind of changed this from like a very, very difficult, highly specialized treatment to like pretty straightforward, mindless field of medicine, which was awesome because it's like, I don't have to work very hard and get these great outcomes for these patients. And then, yes, like there's been additional drugs that have since come on the market, and these have become really effective. I will say though, in my experience, we haven't had a lot of issues getting insurance to cover it, to get Medicaid to cover it, or to have patient assistance programs that manufacturers provide for uninsured patients. So if you guys are interested, if you have a patient who has any form of hepatitis C, they should get treated. And I would not think about those components in terms of whether you are referring them to treatment. Just if you guys are providers who prescribe medications, you should start going down that road to treat them, or don't hesitate to refer them out for treatment. Don't let things like insurance status kind of go in the mix. So all together.
Fantastic. I love this. This is exactly how I like the presentation, because I'm a big ham. I like to be the sage on the stage. And I have Asher here as the guide by the side. Right? It's going to keep me honest. Love it. Hepatitis C treatment needs in North Carolina, only about this graphic shows that only about 1 in 5 people with confirmed hepatitis C are cured within a year. And I hear it in my clinic more often than I'd like. Is someone I ask, have you ever been tested for hepatitis C? Yes. I have hepatitis C, but you know, it's not bothering me. So I'm not really worried about it. Because they've got chronic, and that means that they're not showing any symptoms. Well, that's when we have to have a long conversation. And that's when my program director is going to say, you got 3 patients waiting for you. Because I'm not going to let them leave the office without some type of thing in their hand that says, I can get treatment. And now we have telehealth available, so they don't even have to leave the comfort of their own home to get treatment for hepatitis C. There's lots of barriers to care. One of the major barriers to care is the lack of specialized treatment providers like infectious disease doctors or liver doctors. But we don't have to refer them to a hepatologist to get the treatment. Studies have shown that nurse practitioners and primary care docs can treat just as successfully as specialists, especially since you don't have to determine the genotype anymore of the hepatitis C, because the new treatments, the new regimens will cover all of the genotypes. Now, specifically in my practice, I'm actually going to start with the urging of my program director. I'm going to start treating our patients for hepatitis C, which is something that is not often done in OTP, but we're actually allowed to do it now. We've got a strict set of criteria and a policy set forth by the company that says if they have a certain level of fibrosis, we're going to send them to a specialist. But if they're within this parameter, we can go ahead and treat them, and we're going to start doing that, and I'm pretty excited about that. So who should refer to a specialist? Just like I said, any history of decompensated or advanced cirrhosis or a history of liver transplant. Usually you refer if they have, unless you're very experienced and comfortable, if they have an untreated hepatitis B or a co-infection with HIV, those folks need to see a specialist. Other barriers to care in co-location. So, co-located hepatitis C and opioid use disorder treatment has good outcomes. This has been shown in studies both primary care settings and also harm reduction settings. Does ongoing drug use pose a barrier to treatment? The answer is no. In this study, it was found, this study here called concurrent initiation of hepatitis C and opioid use disorder treatment in people who inject drugs. This study showed that the outcomes are comparable despite whether a patient had ongoing drug use. Co-location of care. In fact, receiving and remaining on opioid use disorder treatment was found to be associated with much higher rates of hepatitis C cure. So, MOUD and hepatitis C are likely synergistic, which means that treating one probably improves the patient's chance of success for the other. This is exciting. Do you know what this means? This means that if you have a patient who has hepatitis C and is receiving treatment for opioid use disorder, treating their hepatitis C is going to improve their retention rate for opioid use disorder. Likewise, if you have a patient with opioid use disorder, or if you have a patient with hepatitis C and opioid use disorder, and you're treating them for their opioid use disorder, the chances are better that they're going to go ahead and get the treatment for hepatitis C. So it's synergistic. They work together. Pretty exciting stuff. Tools to help with hepatitis C virus care. How are we doing on time? Because I want to make sure there's enough time to talk about HIV and infective carditis. Yes, good time. North Carolina, our state runs something called CHAMP, the Carolina Hepatitis Academic Mentoring Program. This is a telemedicine training program for primary care providers that meets briefly once a month to coach you through the care of hepatitis C. It provides expert mentors who are available to discuss complex cases, and they provide continuing education credit. There are a couple of upcoming trainings around hepatitis B and hepatitis C, and here is the contact information for the coordinator at the Department of Health and Human Services, Anthony Hanna. There's also something called Project ECHO. Project ECHO is essentially North Carolina's version. CHAMP is essentially the North Carolina's version of the ECHO program. ECHOs are well-studied programs that provide case-based learning and case discussion during virtual meetings in order to teach providers how to provide care, like for hepatitis C, so that they may otherwise they may not have felt comfortable doing. There's also the National Clinical Consultation Center, which is essentially a free phone service that can be contacted out of California that will provide guidance and consultation on management of hepatitis C, as well as other issues like PrEP and HIV and substance use care. In terms of online resources, the best sites are hcvguidelines.org, which are the official guidelines for hepatitis C care, and they're easy to read and regularly updated. Hepatitis C Online is a more in-depth website if you'd like to take a deeper dive about the topic, that pathophysiology that we managed to pair out. So now we get into HIV. In the United States, 1.2 million people are infected. Now that sounds like a lot, right? But statistics is a funny thing. 1.2 million people sounds like a lot, but how many people are there in the United States? About 330 million. So this is less than 1%. It's about 0.33%. There's 30, in 2022, there was 31,800 new infections, and up to 13% were unaware of their infection status. The South, down here where we live, has the highest rate of new infections. Risk factors is unprotected sex, and of course, injection drug use via blood-contaminated drugs, equipment, or other supplies, occupational exposure like needle stick, pregnancy, and breastfeeding. All of these risk factors can be mitigated if the person with HIV is on effective antiretroviral therapy. In other words, HIV medications. The transmission risk is listed on this slide. This shows how commonly HIV is transmitted by different exposures. Injection drug use is some of the highest risk, estimated to be 1 out of 150 episodes of sharing needles. So it's like playing Russian roulette. You share a needle, maybe not the first time, maybe not the 10th time, but eventually you share needles you're going to end up with an infectious disease, and HIV is one of those. So even in that situation, people need to share injecting equipment many times, are likely to acquire HIV. That being said, if the risk factors are cumulative. If you're having sex with HIV drug users and you're an IV drug user, your risks accumulate exponentially. Here's the natural history of the acute infection. Days to weeks after the exposure is often flu-like illness with adenopathy. It goes through stages. After first contracting the virus, you get that flu-like illness. It's nondescript symptoms, just like with hepatitis. And that resolves, and the patients enter the latent phase, where they have no symptoms, but during that time, the CD4 count cell drops. CD4 is the specific killer T cells that are destroyed by HIV. So the CD4 cells are the immune cells in our system. This lasts for years, and over the course of many years, the CD4 count drops low enough that the patient's immune system is compromised. And that typically happens when your CD4 count drops below 200. And then you become susceptible to just anything that comes down the pipe. The flu, common cold can kill you at that point. At the last phase, when the CD4 count is below 200 and the patient is said to have AIDS, so they're gone from being HIV positive to having AIDS, which is acquired immunodeficiency syndrome. Before that, for years, they may have no major health issues from it, but they can still transmit HIV during that period while they're asymptomatic. The standard HIV test in most settings is combined antigen antibody test. So antibodies, we know what those are. Those are the things that the body creates to fight off an infection. But what's an antigen? If an antibody is the thing the body creates to fight a virus, what is an antigen? What's an antigen? Well, antigen is the pathogen. Antigen is the opposite of antibody. So antigen is the HIV virus itself. So this is pretty good for detecting HIV at any point, but it's not perfect for acute HIV. So in high-risk individuals such as injection drug user with compatible clinical syndrome or acute HIV, that is that they had flu-like illness and swollen lymph nodes, you can send an RNA test as well, which will detect HIV within a few days, and that's detecting the viral load or the antigen. Those terms are used synonymously. The United States Preventive Services Task Force, or USPSTF, recommends routine screenings for all adults ages 15 to 65. Frequency of screening is not specified. However, people who are at high risk, such as those with recent incarceration or ongoing injection drug use, should be tested every year. Looking at the incidence and prevalence of HIV, through 2014 there was a decreasing IDU-related injection drug use related HIV, but improvements leveled off among white rural populations. Since then, we've seen an increasing rate of HIV due to injection drugs in the large rural and small urban areas across the United States. Since 2014, we've seen numerous outbreaks of HIV in groups of rural people using injectable drugs. The most notable was Scott County, Indiana, in 2014-2015, where there was 181 new HIV infections, and nearly all acquired hepatitis C as well. Since then, there have been additional similar outbreaks across the country. We've got articles by Lawrence and Lowell, Lawrence and Lowell, Massachusetts, in 2015-2018, there was 129 cases. In Seattle, 2018, 14 cases, and in West Virginia, 82 cases. Here's the future hotspots that are predicted for new HIV infections. And you can see we're right in the crosshairs. North Carolina is in a hotspot of this 4-state area. And what do you know about infectious disease, by the way, when you're looking at maps? Is there anything that you can tell? Is there any correlation that you can tell when you're looking at maps and infectious disease, especially sexually transmitted disease? Does anybody know a correlation that you can see sometimes when you're looking at a map? Interstate highways, because that's how the infection travels from state to state, interstate highways. So what do we have here in North Carolina? But we have a lot of intersections of famous highways, I-85, I-95, I-40. So that puts us right in the perfect storm for getting future hotspots.
I just want to make a quick comment about this. So this is like a map put out by the CDC. So maybe some of you guys remember hearing about this big HIV outbreak about 10 years ago in Indiana. Mike Pence was famously governor at the time. And a lot of young folks in a very rural area got infected with HIV in the setting of injecting oxymorphone, which I don't think is on the market anymore. What was it? Prescription opioid. This is kind of the CDC's projection about where something like that might happen in the future. And yeah, there's Dr. Ron was saying it tends to be kind of concentrated in certain areas, and this is actually concentrated really in the Appalachian kind of corridors.
Yes.
Folks in here from the western part of the state, I'm sure have been aware of some of these risks for a while, and this graph's a little bit old, so maybe it's changed. But if you guys are, but an outbreak like that is really real and of great concern, and can progress very quickly and really radically change the nature of the care and services that we'll be providing for our patients. And so, thankfully it's not been a huge issue in North Carolina, but if any of you guys in your practice start seeing 1, 2, 3 folks entering your care, recent injection drug use with newly acquired HIV, big concern. You know, make sure your group knows about it, possibly alert someone at the state health department, because that type of thing will progress very, very quickly throughout the community, and can be a real major threat. So you guys are kind of, in some ways, kind of first line providers for things like that. So I want to make sure that's under there.
Thank you for that, because looking at the map again, you're right. This is not the I-85 or 95 corridor here. This is very rural. In fact, it looks more like Verizon's map of where you don't have coverage. This is West Virginia, so you go up in the mountains of West Virginia, you're not going to have any cell phone coverage. Very rural. In terms of HIV infections in North Carolina, they're all over the state. These were new infections in 2023, and we show this just to point out that infections are not solely concentrated in urban centers like Durham and Mecklenburg County, but rather densely occurring in less metropolitan areas such as the southeastern United States, southeastern North Carolina, down here in Lumbee country. HIV treatment. Pharmacotherapy in 2025 is easy and highly effective. There's lots of options with daily, single, tablet, multi-drugs. It used to be where folks had to take a whole handful of drugs every day, pills, and they had to take them exactly the same time every day. But now it's a lot easier. You've got combination medications, long-acting injections that can be given once every 8 weeks. And the drugs are pretty well tolerated with few side effects and not many drug interactions, especially that which interacts with opioid use disorder. And that reminds me, speaking about hepatitis C, I'm not doing a plug for any particular company, but 2 of the main drugs that we use for hepatitis C now are Mavorix and Epclusa. So I'm a big fan of Epclusa because Mavorix seems to have an interaction with methadone. So Epclusa is the one that doesn't. Shout out to Gilead. Where's Gilead? They're not here. Good. Okay, there they are. I'll collect my check. Just kidding. I might get. I heard that we might get an honorarium from the governor's institute. It's a nonprofit, so we can't expect more. General treatment principles are to treat all patients with HIV and start as soon as possible. Some clinical centers or settings even have a rapid start program, meaning at the same time you visit, you can get a rapid test, be diagnosed with HIV, and have HIV medications put in your hand to start immediately if you're positive. There's also a concept of treatment as prevention, meaning that if you receive treatment for HIV, you're less likely to transmit to others, and that's what this next slide is about. This is pretty exciting. The CDC, Centers for Disease Control down in Georgia, says you versus you, undetectable equals untransmittable. A person living with HIV who has an undetectable viral load does not transmit the virus to their partners. It's pretty big news.
Yeah, I'll just say for context, so when we treat HIV, our treatment goal is, it's really great because we can monitor how patients are doing by monitoring something called the viral load. That's essentially just, if you take a blood test, how much of the virus are you finding in a certain amount of their blood? And when people aren't on treatment, that number is sky high. And when people are on treatment, it very quickly drops down to being so low you can't detect it. And that's what people mean when they say they are undetectable. And when people are undetectable, that virus level is suppressed. They're not cured, because if they come off their medications, then that viral load will go back up. So we consider it like we're suppressing the virus down, keeping it down, holding it down at that undetectable level. And the current modern drugs are really great. They pretty much all can get folks down to undetectable levels quickly with virtually no major side effects. So again, I'm biased, but like Hep C, HIV medicines become kind of like mindless, like maybe out of a job soon, because it's not very hard. It doesn't require a lot of thought. It always works. People the big issues are making sure folks are taking their medications. If folks do, they will be undetectable. When you're undetectable, then A, you are not having health consequences from HIV any further. Your immune system is allowed to recover because it's not being attacked by virus constantly. And folks can just live a totally healthy life. And B, they're not at risk of transmitting it to others. They have such little virus in their blood at a given moment. If those folks have sex, condom or no condom, with someone else, they are not going to transmit HIV to someone else. And so it's really kind of changed the way we think about HIV and HIV prevention. That you can prevent HIV not just by the person who's at risk, but by treating the person who has HIV. If you treat them, get them to an undetectable level, you're preventing HIV on a community level at large. And this has been studied scientifically in major trials. So it's not just a theoretical concept, it's very much a kind of real treatment phenomenon.
Love it. Asher is an unusual type of doctor because he's really working his way out of a job. Once all these infectious disease have cures, he'll have to do something else, right? Just like that scientist on Jurassic Park when they said, well, we can't have paleontologists anymore because we got the real dinosaurs. So, furthermore, patients will be able to live full, complete lives because of the treatments that are available. Pretty exciting technology that's available. Here's the outcomes of HIV in North Carolina. They're good, but we still have a long way to go. Of the patients that are diagnosed with HIV in the state, 77% have seen an HIV provider once. 71% are retained in care, meaning that they've been seen regularly, and 67% have undetectable viral loads. Wow, 2/3 of these patients have undetectable viral loads. Wow. In terms of risk factors for getting HIV in North Carolina, injectable drug use is fairly uncommon. Each year accounts for about 8% of new HIV cases. So remember I said hepatitis is so much easier to catch than HIV because HIV can't live outside the host. However, patients who acquire HIV from injecting drugs have worse outcomes. This graph shows the different HIV outcomes based on the way the person got HIV. for those who acquired HIV from injectable drug use. The second group of columns here, they have lower rates of retention and care and viral suppression. This means that if they're continuing to inject illicit drugs, they're more likely to transmit HIV than others. It's also a marker of some of the psychosocial issues that impact our ability to get specialized care to people who inject drugs. Opioid use disorder care for people with HIV. Among people with HIV who have OUD, many get great HIV care, but still receive inadequate care for opioid use disorder. It's worth noting that North Carolina's HIV medication assistance program does not cover MOUD or naloxone. This is a state-based insurer that provides key medications for people with HIV who are uninsured. In our state, while they cover many HIV medications and other important primary care medications, they do not cover MOUD. So this reminds me of a lot of things that North Carolina does a little backwards at times. Kind of like I was talking to somebody last night who said that they have someone who needs to be in a nursing home, and they need to find a nursing home that also participates in OTP. And they said, if you can find one, let me know. Seems like a no-brainer, but apparently hard to find, because a lot of these nursing homes are afraid of taking someone with opioid use disorder, because of course we know why. Preaching to the choir here. This is kind of cool too. Pre-exposure prophylaxis, also known as PrEP, is a concept of taking HIV medications to prevent HIV acquisition. PrEP refers to the concept, not a specific drug. There are 4 drugs available for PrEP, 2 options that are once daily, and one that's an injection every 8 weeks. There's even one that you can get now for once every 6 months, an injection for pre-exposure prophylaxis. For people who inject drugs or have other behaviors or high risk for acquiring HIV, PrEP is recommended. However, it's widely underutilized for people who inject drugs. So if you're in one of these high-risk groups, like people who inject drugs, it's recommended that you go on this pre-exposure prophylaxis, which can prevent HIV infection, but it's still pretty underutilized. There's also a concept of post-exposure prophylaxis, that is taking HIV meds after an exposure to prevent acquiring it. This needs to be done within 72 hours and can be in response to a sexual or needle stick exposure. Patients should be referred urgently to a clinic if they report an exposure and are within the time frame. This reminds me of when the first treatment for HIV came out was AZT, and it was also pretty exciting because up until that point there was no way to prevent the transmission of HIV to an unborn fetus until AZT came out, and they said, hey, if we go ahead and give AZT, we can prevent that transmission. I want to highlight how all of these tools can come together in public health infrastructure to address HIV outbreak among people who inject drugs. This is an outbreak in West Virginia from 2018 to 2019 and shows the steps that were taken to stem HIV cases. The black line shows HIV cases rising and eventually leveling off, and then all of the steps that were taken. These included expanding syringe programs, expanding HIV testing in the community, training providers to provide PrEP, providing HIV care at these syringe programs, providing MOUD in HIV care settings, and many other elements, in addition to ongoing communication throughout. Eventually, these steps all led to a leveling off of new infection. So this is a really great graphic. Other severe infections. Now we're moving into an area that is not my specialty, but definitely Asher's. invasive infections that land patient in the hospital, like infective endocarditis, spinal infections like epidural abscess, vertebral osteomyelitis, bone joint infections, bacteremia, severe skin infections, and these are not typically transmitted person to person. They bring to the stage a lot of really difficult issues, such as how patients may present and get very late care for something, the needs for pain control and addressing their opioid cravings in the hospital, and the physician-patient power dynamic and against medical advice discharges. This is something pretty near and dear to both Asher and I. In fact, I see patients a lot that face the stigma and are concerned, and then they kind of say, well, I've got, let's say they've got something like, from injecting drug use, they have something like a chronic staph infection, and it just flares up in their leg every so often, and they get a really red swollen leg, and they say, well, I just need to go and get a course of antibiotics and steroids, and it'll go away, it'll come back, it'll flare up. Well, if they saw somebody like Asher, maybe they wouldn't come back. Oh, thank you. What is infective endocarditis? Yes, please. This is
I'll talk for a little bit too.
Asher's
Some
Valley
other topics. I have like a whole, my MO often is just to like pack tons of stuff in here, and we may or may not get to everything. And as we start to run out of time, I think that maybe should be a little bit more of what Dr. Ron said of just kind of interrupting us, because otherwise I'll just keep talking and talking. But yeah, our charge was to discuss HIV and hepatitis C.